Lecture of chemical dependency, substance abuse, and addictive disorders. Substance abuse is the #1 health problem in the United States. It's an equal opportunity disease. Alcohol was involved in 60% of all fatal accidents and 50% of suicides and homicides and 56% of domestic assaults. The American Psychiatric Association, or APA, in 2013 identified the following substance-related and addictive disorders: alcohol, caffeine, cannabis, hallucinogen, inhalant, opioid, sedative, hypnotic, anxiolytic, stimulant, tobacco, and other substances. Internet gaming, the use of social media, shopping, and sexual activity are also considered to be addictive. Behavioral addictions are also referred to as process addictions. Gambling and other compulsive actions activate dopamine and glutamine in the reward or pleasure neural pathways of the brain's limbic system, just like substances do. The activities are reinforced through the dopamine-glutamate cycle and may become dysfunctional for the individual, resulting in many of the same problematic behaviors and functional issues as the ingested substances. Substance abuse is often associated with other mental health illnesses like polydrug use, dual diagnoses, and psychiatric and medical comorbidities. Approximately 6 out of every 10 people affected by a substance abuse disorder is also affected by a mental health disorder. Individuals who abuse alcohol are more likely to abuse other substances and vice versa. Alcohol dependence is associated with abuse of other substances, mood and anxiety disorders, and paranoid, histrionic, and antisocial personality disorders. The brain has a reward system that facilitates cravings and triggers for reusing. Addiction is a compulsive, uncontrollable craving for and dependence on a substance to such a degree that cessation causes severe emotional, mental, or physiologic reactions. Drug addiction should be considered a complex disease of the central nervous system, characterized by a compulsive, uncontrolled craving for and dependence on a substance. Chemical impairment is a term used by health professionals to describe behaviors related to the effects of drugs or substances on performance. Dependence is reliance on a substance that has reached the level that its absence will cause impairment in function. Codependence is a term used to describe coping behaviors that prevent individuals from taking care of their own needs and have as their core a preoccupation with the thoughts and feelings of another or others. Usually refers to the dependence of one person or on another person who is addicted in one form or another. Drug abuse is overindulgence in and dependence on a substance that has a negative impact on psychological, physiologic, and social functioning of an individual. It's synonymous with chemical dependence. Drug misuse is indiscriminate use of a drug for purposes other than those for which it is intended. Drug abuse is culturally defined and may be considered drug use inconsistent with medical or social norms. Tolerance is the decreased effect of a substance that results from repeated exposure. It's possible to develop cross-tolerance to other substances in the same category. Tolerance occurs when a person's physiological reaction to a drug decreases with repeated administrations of the same dose. Withdrawal also causes physiologic changes to occur when blood and tissue concentrations of a drug decrease in individuals who have maintained heavy and prolonged use of a substance. Remember that those who have substance addiction still need to be treated for pain, but may require more to achieve pain relief. Withdrawal is the physiologic and psychologic responses that occur when there is abrupt cessation or reduced intake of a substance on which an individual is dependent. The systems are often opposite the effects the drug produced before it was withdrawn. Opioids, alcohol, barbiturates, and anxiolytics have a strong physical dependence and withdrawal syndrome. Cannabinoids and amphetamines have a weaker physical dependence. LSD does not cause physical dependence, and treatment includes slow weaning of the drug. So click pause to play the interactive video Mouse Party. Do the couch mouse for heroin, the white mouse for meth, and the tan mouse for alcohol. Within seconds of entering the body, drugs cause dramatic changes to synapses in the brain. By bypassing the five senses and directly activating the brain's reward circuitry fast and hard, drugs can cause a jolt of intense pleasure. Normally, dopamine is released at a slow rate in the mesolimbic system, producing a normal mood. Certain drugs increase the release of dopamine or decrease its reuptake at the synapse. The increase in dopamine leads to euphoria, which provides strong motivation to repeat the experience. Many addictive drugs also increase the availability of other neurotransmitters, such as serotonin and GABA, but dopamine's effect on the reward system appears to be pivotal to the addictive process. Addiction results from the prolonged effects of addictive drugs on the brain. Repeated use of drugs remodels the neural circuitry of the brain cells and reduces the responsiveness of receptors. This decreased responsiveness leads to tolerance, which is the need for a larger dose of a drug to obtain the original euphoria. As drugs of abuse result in levels of dopamine that do not naturally occur, it also reduces the sense of pleasure from experiences that previously resulted in positive feelings, such as food, sex, or relationships. Without the drug, the individual may experience depression, anxiety, and irritability. Craving is another characteristic of addiction. Cue-induced craving occurs in the presence of people, places, or things, and have previously been associated with drug use. New studies indicate that these encounters produce surges in dopamine levels, and these surges push the individual toward active drug seeking and drug taking. Cue-induced craving may occur after long periods of abstinence and is a common cause of relapse. Assessment across the lifespan will include perinatal, children, teens, adults, families, healthcare workers, and the elderly. For patient safety, any suspicions of alcohol or drug use should be explored and reported because of potential for cross-tolerance. Current alcohol and other drug problems can be detected by asking two questions. In the last year, have you ever drank or used drugs more than you meant to? And have you felt you wanted or needed to cut down on your drinking or drug use in the last year? Ask questions in a matter-of-fact, non-judgmental fashion. Specific details include name of drugs used, the route, quantity, time of last use, and usual pattern of use. Responses that serve as red flags include rationalizations such as, you'd smoke dope too if, and automatic responses as if the question were predicted. I figured you'd ask me that. And also slow, prolonged responses as if the person were being careful about what to say. If the patient is unable to provide a drug history, the nurse should assess for indications of substance abuse that may include dilated or constricted pupils, abnormal vital signs, needle marks, tremors, alcohol on the breath, or a history from family and friends. Their clothing should be checked for drug paraphernalia such as used syringes, cracked vials, white powder, razor blades, bent spoons, and pipes. Urine or blood may be required to test for drugs and alcohol. Defense mechanisms are usually unconscious, intrapsychic processes used to ward off anxiety by preventing conscious awareness of threatening feelings. Defense mechanisms can be used in a healthy or a not so healthy manner. Examples are repression, projection, sublimation, denial, and regression. Primary prevention through health teaching can have an important impact on how children and adolescents choose to solve problems and relate interpersonally. Young people who participate in groups such as scouting, 4-H clubs, school clubs, and organized church activities are at a lower risk for substance abuse. Activities help develop self-confidence and self-esteem. Older adults experience stressful life events are also at risk for substance abuse. This population may be reached through senior citizen centers and other community, social, or spiritual groups and organizations. The nurse can play an important role in the intervention process by recognizing the signs of substance abuse in both the patient and the family. Being familiar with the resources available to help with the problem is important. The aim of treatment is self-responsibility, not compliance. Inpatient or outpatient care depends on cost and the availability of insurance coverage. Outpatient programs work best for people with substance abuse disorders who are employed and have an involved social support system. People who have no support and structure in their day may do better in inpatient programs when these programs are available. Relapses are common during a person's recovery. The goal of relapse prevention is to help the individual learn from these situations so that periods of sobriety can be lengthened over time. Lapses and relapses are not viewed as total failure. Use of brief interventions based on the FRAMES model to effect behavior change allow the nurse to take advantage of any interaction with a substance abusing patient and use it as an opportunity for managing associated behaviors. And FRAMES stands for feedback of personal risk, responsibility of the patient, advice to change, menu of ways to reduce substance use, empathetic counseling, and self-efficacy or optimism of the patient. Counseling and support should be encouraged for all family members of a person with a chemical dependency. There is no antidote available for alcohol, and stimulants should not be given. Alcohol may be removed from the body by gastric lavage and dialysis. Push pause to watch the video Alcohol Withdrawal featuring Drunk Brain. Alcohol is a central nervous system depressant. It affects neurons in the CNS like GABA. It binds with receptors in the brain reward system, resulting in the release of dopamine and promoting the addictive process. It's absorbed from stomach and intestines. Slower absorption with the presence of water or food, faster absorption when mixed with carbonated liquids. It can damage every cell in the body and crosses the placenta. Alcohol is metabolized in the liver. The liver can only accommodate about 1 drink per hour, and it's eliminated through kidneys and lungs. One standard drink contains roughly 14 grams of pure alcohol, which is found in 12 ounces of regular beer, which is usually about 5% alcohol, 5 ounces of wine, which is typically about 12% alcohol, and 1.5 ounces of distilled spirits, which is about 40% alcohol. Moderate or low-risk drinking includes research that shows people who drink moderately may be less likely to experience an alcohol use disorder. Men should not have more than 4 drinks on any single day and no more than 14 drinks per week. Women should not have more than 3 drinks on any single day and no more than 7 drinks per week to be considered low risk. Heavy or at-risk drinking is consuming more than the single day or the weekly amounts that I just told you. About 1 in 4 people who drink above these levels already has alcohol dependence or alcohol abuse problems. Binge drinking means drinking so much within about 2 hours that blood alcohol concentration levels reach 0.08. With women, this usually occurs after 4 drinks, and with men, it usually occurs after 5 drinks. The concentration of alcohol in the body can be determined by assessing the blood alcohol concentration. Blood alcohol level, or BAC, is dependent on how much alcohol is consumed, how fast it is consumed, and the individual's weight. For the non-dependent drinker, the BAC is fairly predictable of alcohol's effects. Alcoholics are able to drink large amounts without obvious impairment at BAC levels several times higher than those in the non-tolerant drinker. Little tolerance develops to respiratory depression. Chronic heavy alcohol users reach the lethal BAC at almost the same level as non-users. Push pause and watch the video Helping Patients Who Drink Too Much. Complete the case studies in the video for Daryl, who goes through all 4 steps, and Teresa, who goes through selected steps. With the history and physical, you should screen for coexisting medical and psychiatric problems and assess for concurrent drug abuse. Assessment tools can include SBIRT, which is screening, brief intervention, and referral to treatment. CAGE, an acronym for Catenoid Guilty Eye, CAGE. The CAGE assessment is a 4-question yes/no questionnaire to help determine if an alcohol assessment is needed. Questions include: have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? And that's the eye opener for the CAGE. Another tool is the Short Michigan Alcohol Screening Test, or SMAST, and the CAST, C-A-S-T. And this is used to identify adolescent and grown-up children of alcoholics. It's important to use brief interventions based on the Frames model to affect baby behavior change and allow the nurse to take advantage of any interaction with the substance abusing patients and use it as an opportunity for managing associated behaviors. Again, the Frames model is feedback of personal risk, responsibility of the patient or personal control, advice to change, menu of ways to reduce substance use or providing options, empathetic counseling, and self-efficacy or optimism of the patient. Counseling and support should be encouraged for all family members of a person with a chemical dependency. So some long-term effects of alcohol. Wernicke's encephalopathy is a preventable, inflammatory, hemorrhagic, degenerative condition of the brain resulting from a deficiency of thiamine due to malnutrition associated with chronic alcohol use. Untreated or progressive Wernicke's encephalopathy may lead to Korsakoff's psychosis. It's a form of amnesia characterized by loss of short-term memory and an inability to learn. People can get a fatty liver, alcohol hepatitis, fibrosis, and cirrhosis, and may want to look up hepatic encephalopathy because that might be important for you to know in the future. Can develop GI bleed, Barrett's esophagus and pancreatitis, cardiomyopathy, arrhythmias, hypertension and stroke, mouth, sores, esophagus, throat, liver and breast problems, and it weakens the immune system so they can get pneumonia or TB. With alcohol withdrawal, non-dependent drinkers experience hangovers that are manifested by malaise, nausea, headache, thirst, and a general feeling of fatigue. Withdrawal symptoms should be anticipated if the individual reports consumption of more than 10 drinks every day for a period of 2 weeks. 4 characteristic signs of withdrawal are gross tremors, seizures, hallucinations, and alcohol withdrawal delirium. Early signs of withdrawal develop within a few hours after cessation, normally within 4 to 12 hours. That's also important for you to remember. It peaks 24 to 48 hours and then rapidly and dramatically disappears unless the withdrawal progresses to alcohol withdrawal delirium. Symptoms include being hyperalert, manifest jerky movements and irritability, startle easily, and experience subjective distress, often described as shaking inside. Grand mal seizures may appear 7 to 48 hours after cessation of alcohol intake, particularly in people with a history of seizures. Illusions are usually terrifying for the patient. Illusions are misinterpretations, usually of a threatening nature, of objects in the environment. For example, a person may think spots on the wallpaper are blood-sucking ants. Illusions can be clarified, which reduces the patient's terror. See, they are not ants, they are just part of the wallpaper pattern. Alcohol withdrawal delirium is considered a medical emergency and can result in death. Death is usually due to sepsis, myocardial infarction, fat embolism, peripheral vascular collapse, electrolyte imbalance, aspiration pneumonia, or suicide. It peaks 2 to 3 days, or 48 to 72 hours, after cessation or reduction of intake, although it can occur later, and can last 2 to 3 days. Symptoms include anxiety, insomnia, anorexia, and delirium. Autonomic hyperactivity like tachycardia, diaphoresis, and elevated blood pressure. Severe disturbance in sensorium like disorientation and clouding of consciousness. Perceptual disturbances like visual or tactile hallucinations. Fluctuating levels of consciousness ranging from hyperexcitability to lethargy. And delusions, paranoid, agitated behaviors, and fever, sometimes between 100 to 103. A CWA assessment includes vital signs, nausea, vomiting, anxiety, paroxysmal sweats, tactile disturbances like itching, pins and needles sensation, burning and numbness, visual disturbances like too bright, color changes, illusions, tremors and tremors of the hands and fingers, agitation, orientation, auditory disturbances, and headache. Treatment may include thiamine or vitamin B1 because symptoms of Wernicke's encephalopathy may be difficult to distinguish from those of intoxication, and because Wernicke's encephalopathy is potentially reversible. IV thiamine at a dose of 100 milligrams per day is often administered to intoxicated patients. Multivitamin with folic acid and vitamin B for nutritional support is administered. And glucose is given. The patient may experience hypoglycemia due to lack of food intake. Glucose solutions may precipitate Wernicke's encephalopathy in a previously unaffected patient. For this reason, thiamine should be started before treatment with IV glucose solution in all patients with alcoholism and continued until the patient resumes a normal diet. Benzodiazepines are given to decrease the intensity of withdrawal symptoms and prevent alcohol withdrawal delirium. Librium and Ativan are given if the patient has liver dysfunction. Benzodiazepines with long half-lives and stabilize vital signs, reduce symptoms, and decrease the risk of seizures and delirium. Monitor vital signs and respiratory status with these. Haldol is used for hallucinations and delirium, and Tegretol or Dilantin is used to prevent or treat seizures. A kind, warm, and supportive manner on the part of the nurse can allay anxiety and provide a sense of security. Consistent and frequent orientation to time and place may be necessary. Encouraging the family or close friends one at a time to stay with the patient in quiet surroundings can also help increase orientation and minimize confusion and anxiety. Rehabilitation and sustained abstinence are the primary long-term goals of alcohol treatment. Medications include antabuse, which prevents drinking by causing an unpleasant reaction if alcohol is consumed. It disrupts alcohol metabolism, causing accumulation of acetaldehyde when alcohol is ingested. Adverse reaction includes flushing in the face, intense vasodilation of the face, neck, and upper part of the body, hyperventilation, palpitations, nausea and vomiting, headache, sweating, thirst, chest pain, weakness, blurred vision, and hypotension. It lasts from 30 minutes to several hours and can be brought on by ingesting as little as 7 mLs of alcohol. In the absence of alcohol, it may cause drowsiness and skin eruptions that diminish over time. The effects may persist for up to 2 weeks after the last dose is taken. It's important for you to provide education. Consumption of any alcohol can cause a reaction. All food and liquid medication labels must be checked for alcohol, and alcohol must not be used on the skin. Alcohol can be found in mouthwashes, aftershave, colognes, perfumes, paint thinners, solvents, stains, lacquers, and over-the-counter cold medicines. It is self-administered, so patients must be highly motivated to abstain from alcohol for it to be effective. Additionally, utilizing a family or other strong support system improves adherence to daily dosing. Camprol is used to decrease unpleasant feelings such as tension, dysphoria, anxiety, and cravings brought about by abstinence from alcohol. Camprol is thought to act on the brain pathways related to alcohol abuse. Dosing should start immediately after detoxification and continue even if relapse occurs. It's not addicting but is somewhat less effective than naltrexone. Combining Camprol with naltrexone is more effective than Camprol alone, but it's not any better than naltrexone alone. And the most common adverse effects reported include headache, diarrhea, flatulence, and nausea. And then the last treatment is naltrexone, which decreases cravings for alcohol and blocks the desired effects. 50 milligrams once a day by mouth is the usual dose for alcohol dependency. It's available in an injectable, extended release form called Withdrawal that is given intramuscularly once a month. This drug is indicated for alcohol-dependent patients who are able to abstain from drinking in an outpatient setting and are not actively drinking when starting treatment. So this ends the first part of this lecture. We'll continue on with part 2.